Hi, everybody. This is Michelle Dufresne, and I am going to be talking to you about tissue integrity, supplemental to the lecture that was presented earlier in the month um, for test 3. So, tissue integrity is the state of structurally intact and physiological functioning epithelial tissues, such as the integument and mucous membranes. In your concepts book, tissue integrity is defined as to include integumentary, mucous membranes, carnal tissue, subcutaneous tissue that's uninterrupted. There's a picture in the presentation of the structures of the skin, and then just to outline a couple things about it. The epidermis is the outermost layer, made up of 7 different types or layers of cells. The dermis is next. Within the dermis, what's significant is this is where our nerve tissue shows up. Capillary beds show up also. And then we have the subcutaneous layer, the very bottom layer, and it is where our sweat glands and arteries and veins originate in the skin. The functions of the skin are what you need to focus on, really. So it's outlined for you here on slide number 5. Protection, sensation, heat regulation, control of evaporation, aesthetics and communication. It's a psychosocial function. Storage and synthesis, excretion, absorption, and water resistant. So for protection, its anatomical barrier is what it provides us to protect us from pathogens or anything from our external environment to invade the body. Sensation, it's where our nerve endings are in the dermal layer of the skin. So we can sense heat, cold, touch, pressure, vibration, injury. In that sense, is protective. In heat regulation, it contains a great amount of blood vessels in the dermal layer. It dilates blood vessels to increase perfusion and heat loss while constricting vessels to greatly reduce the blood flow and conserve heat. Then for evaporation, it provides a relatively dry and impermeable barrier for fluid loss. Aesthetics, it's what we see. And we can use it to assess our health, our mood, physical state, attractiveness. That's so in that sense, the psychosocial function. Synthesis and storage. It acts as a storage center for lipids and water, also synthesis of vitamin D. And then excretion of water by sweating is a supplemental function to regulate temperature. Then absorption of good elements like our oxygen, nitrogen, carbon dioxide, which can diffuse into the epidermis in small amounts, providing an important site for transport of gases and nutrients. And water resistance, it's water resistant barrier, which is essential for nutrients that won't get washed out of the body as easily. So those are the functions in general of the skin. It's 9 functions all in tow. The skin also has other things to consider about it. So with genetics, heredity can determine the way our skin will look, the color of it, sensitivity to light and other things in our environment, such as allergens, so allergies. With different age groups, we'll see different risk factors related to our skin. So the very young and the very old, I'm talking about. So in newborns, the first 4 weeks of life, their skin is very fragile and very, very thin, more permeable in the first 2 weeks of life than any other time. So they can be affected by things that touch their skin easily. And then in the elderly, we have problems with regeneration of skin tissue. So it takes longer for our outer layer, the epidermal layer, to turn over and replace dead cells with new cells. There's loss of collagen, so they appear wrinkled. The dermal layer can tear easier because of the loss of collagen and also loss of our subcutaneous layer of in the skin. So then when we lose our fat layer, it makes us more vulnerable to friction and shearing injuries, but it also is where our sweat glands are. So the skin will become more dry in nature, and because of the loss of fat, that fatty layer. And another reason to think about as we age, when we lose our fat layer, we also lose that insulation layer that it provided to help regulate body temperature easier. So they're less likely to control their body temperature and complain more of cold feelings, feeling hot in the summer and cold in the winter. So, and along with changes with aging, we lose our nerve cells and we lose our immune response is not as aggressive. And so in that sense, the results from trauma is less noticed as you grow older, and you have longer healing times because of the immune response not active as normally as before. All right. So those are other considerations with the skin to think about. So slide 7 just reiterates what I just went over. So newborns and infants have thinner skin than adults. Older adults begin to develop thinner, less elastic skin. Chronic illnesses also can affect our skin, and the type of treatment can also impair our skin, such as corticosteroids and other medications that make us more sensitive to this ultraviolet sunlight, such as some antibiotics like doxycycline, tetracyclines, chemotherapeutics like methotrexate, and there are many others. And then some of the psychotherapeutic drugs, the one most notable here would be our tricyclic antidepressants, all make us more sensitive to the sun. So keep that in mind. So when we assess the skin, we are going to talk about who can do that, when, and how. What do you look for? So nurses cannot delegate this task to any other person. So you, the nurse, must do the assessment, must do the actual inspection of the skin. And when the most common and easier times to assess the skin in our patients would be, for example, in the morning when you're doing a bath, maybe, or repositioning the patient. Anytime the patient's being repositioned, you should be assessing the skin. We inspect the skin folds, areas that are moist. So places like the perineum, if they're laying on their backside, then those areas would be more prominent to injury. So we want to inspect those areas. If they're obese, any pendulant abdominal folds under breasts for women who have large breasts, and those kind of things you need to think about. We also want to make sure that we're inspecting the skin that's underneath any type of medical device that's on our patient. So for example, Ted-Hose stockings, SCD devices, or any other type of device. You need to open it up. If it's safe to open and take the limb out or take that device off the skin, you need to inspect the skin underneath that's covered by the device. What do you look for? So you're looking for the color, the temperature, and any type of lesions that may be present. So strong odors also. So you're going to assess for abnormalities. And on the slide number 8, there is a list of abnormalities here presented. So redness, edema, painful areas, primary, secondary lesions, which we'll get into shortly, any pearly centered lesions, dark asymmetrical lesions, multicolored patchy lesions, irregular shaped edges on a lesion, or what is the general shape of it? Is it circular? Is it oblong? How are they grouped or distributed on the area also? Okay. So on slide 9, we have examples of abnormal skin assessments. We have what we call secondary and primary lesions. That is what you need to pay attention to. Should start learning the terminology on this slide. So primary lesions include macules, nodules, pustules, plaques, vesicles, bulla, and papules. So those are the primary lesions. And what I mean by primary is that they changes in the skin is from morphology of the pathophysiology occurring in the skin that develops this lesion. These primary lesions are things like scales, scars, crusty oozing discharge, fissures, erosions, and ulcerated areas. So those are the result of the evolutionary process in the skin that occurs as a result of the pathology or the morphology of that occurs. Okay. So another thing we will use to assess the skin is some of the assessment tools. And the main one I'm going to go over is the Braden scale. So the Braden Risk Assessment Scale is a evidence-based tool that we use in hospitals today. Pretty much all units or hospitals are using the Braden scale. And its purpose is to assess a patient's risk for tissue integrity problem. So that's its main goal, to determine who is at risk when they come into our facility. And it measures 6 subscales. So there's one for sensory perception, moisture, activity, mobility, nutrition, and friction and shear problems. The scale ranges from a score of 6 to 23, and the lower your score indicates a higher risk for tissue integrity issue. So in general, anybody who has a score less than 18 will generally be at risk for some type of tissue integrity problem. Okay, so we're going to look at a case example to try and apply the use of this scale. Within each subscale, it has determinants that measures out how to rate the person for each of the scales in the whole tool. So for our patient, Mr. K, he is admitted, and this is on slide 11, to the hospital ongoing complex medical care for management of advanced Parkinson's disease, dysphagia, and failure to thrive. He developed difficulty swallowing after his unusual Parkinson's medication schedule was inadvertently altered at rehab 1 month ago. He is now designated as having nothing by mouth, NPO, and has trouble with secretions. Mr. K is alert and oriented, but speech and sensory motor function are not smooth and symmetric. Currently, he is being fed Ensure Plus by a feeding tube. Nutrition consult was ordered. He is usually unable to walk and has difficulty talking. He requires total care for bathing, toileting, dressing, and feeding. At least 2 nurses or nurse aides are required to move him. he occasionally is incontinent. A wound consult was done and revealed that he had a slightly pink coccyx, the base of the spinal cord or spinal column. Okay, so that's our case. Now, note that everyone's going to rate things slightly differently according to your assessment and how you perceive him in each of the subscales. But in general, the goal should be, is he at risk or is he not at risk? And how, to what degree is he at risk? Okay, so the first scale is sensation. And for sensation, if we read the scale, having trouble reading my copy here, for a 1, he would not be able to have much sensation at all. I can't read it directly from here, but you hopefully can. Very limited or completely limited is 1. Very limited would be 2, and 3, slightly limited would be 3, and 4, no impairment. So for Mr. K, he can sense pain, touch, vibration, cold, heat. So he has no impairment for that. So he's a number 4 for sensation. Moisture, though, for moisture, he would be, is he constantly moist? Is he very moist? Is he occasionally moist or rarely moist? So he, in our case, he is occasionally incontinent. So he occasionally is moist. So he would be a number 3. Then activity, is he completely bed rest, or can he get up to a chair? Can he walk occasionally or walks frequently? So he can get out of bed, but he needs a lot of assistance. He doesn't move too much on his own in the bed as well. So I'm going to say he's a number 3 because he can get up and bear weight and walk if we have to assist him. Mobility is next. Is he, for 1, completely immobile, or 2, very limited, or 3, slightly limited, or no limitation? So for mobility, I'm rating him at number 2. He is very limited. He cannot move himself with any real purposeful, significant change in body position on his own. So he needs 2 people also to reposition him in the case they state. So he's very limited for me. Number 2 is what I rate. Nutrition, very poor, probably inadequate for number 2. Number 3, he would be adequate, or number 4, excellent. So he is having some difficulty with eating. He has dysphagia, which is difficulty swallowing. They have him to take nothing by mouth, but we are feeding him through a feeding tube. So until proven otherwise, I'm going to say number 2, probable or probably inadequate for his nutritional needs at this time. So I'm rating it a number 2. Then friction and shear, number 1 would be problem. Number 2 would be possible problem. And number 3, no problem. So he's a definite problem for friction and shear. Number 1. My total comes to a 15. Okay, so 15 would make him fall in the moderate risk category, according to the Braden scale, if you look at the interpretation, how to interpret it. So 15, he's a moderate risk. So we're going to do certain interventions that will help patients who are considered at a moderate risk. But if we look at the whole scenario a little closer, the patient already has a slightly pink coccyx. So, and he has a lot of problems with mobility independently already. So even though the scale we rating him at a moderate risk, you can, through your own clinical judgment, make him a high risk patient. So we would do additional interventions in that case if he was considered a high risk patient. All right, so the next slide 13 is going to just list our risk factors for skin integrity problems with patients. So immobility, poor nutrition, dehydration, elderly aged, fecal or urinary incontinence, altered level of consciousness, spinal cord injury, neuropathies, or infection are all the general risk factors for someone who should be categorized as a person at risk. So he has multiple risk factors already in this outline that we could apply to him. So now we're going to look at our first risk, our first problem with tissue integrity, and that is pressure injury. So for pressure injury, any of the risk factors we just outlined still apply. Friction and shearing, immobility, inadequate nutrition, incontinence, decreased mental status, diminished sensation, excessive body heat, and aging, chronic illnesses put you at risk for a pressure injury in this case. And slide 15, this takes us to assessment of wound drainage. Just a brief reminder of what we've already talked about when we looked at inflammation. Serous, purulent, or different types of wound drainage you will see in patients. And you can use these terms and combine them to describe the drainage that you are assessing in your patient. So example would be serosanguinous or purosanguinous. And you should already know the definition of serous, sanguinous, and purulent. Serous is that watery plasma-looking discharge. Sanguinous is the presence of some blood in the discharge, which indicates bleeding occurring. And in purulent, drainage often is an indication of infection in a wound. It looks yellow, thick, green, tan, brown colored discharge. It sometimes has an odor also, which can indicate the type of organism causing the infection. And so other assessment factors that we're going to look at on page slide 16 is outlined here. So your white blood cell count, red blood cell count, platelet, coag studies, serum albumin, and wound cultures are some of the labs that you may want to look for if in your patient's charts to assess their risk for wound injury issues. So white blood cell, the person has a decreased light count. This would be an indication for delayed wound healing and possibly increased infection risk in that wound. And red blood cells, if they have a decreased hemoglobin, they have poor oxygenation delivery capacity for healing. So it also will be an indication for delayed wound healing in that sense. Prolonged coagulation times and others affected by medications such as heparin and PTT, or Lovenox will help prolong your coag time and can lead to excessive bleeding as well, can affect our healing process. Hypercoagulation is the opposite side of this. When you have too many clotting factors, there could also produce clots that help block perfusion to the tissues that need it. So you would see a deficit in blood supply in those tissues if they have clots forming because of hypercoagulation. Serum albumin level. Serum albumin level is a protein that we look at, and it reflects nutritional reserves for building cells. So it's a good indicator for nutrition status. And if someone's albumin level is less than 3.5, this is an indication for poor wound healing also, because they lack the adequate amounts of protein to rebuild new tissue. It also can put them at risk for infection as well. So an albumin level between less than 3.5 is significant to make note of. Wound cultures may be ordered, and you would have to assess them to see if it grew out any causative agents that could be producing an infection. You may be responsible to collect that actual culture if it's used by collecting it by using a culturette. Um, or you may be assisting a physician or a provider to do a skin punch biopsy to also collect the cultures. All right, so our first problem, slide 17, pressure injury. Used to be called decubitus ulcer, pressure ulcers, um, pressure sores, bed sores, you may hear them called. But today, the current accepted terminology is pressure injury because it really reflects the etiology of the injury. So it's an injury to the skin or underlying tissues, usually over a bony prominence, which is significant, a bony prominence, as a result of force alone or in combination with movement, like shearing and friction movements, okay? Sliding kind of injuries. Intact skin or intact tissue requires only intermittent blood flow to maintain viability. Limited periods of ischemia are well tolerated by soft tissue. That's a significant principle to understand. And it is the reason why we say it is safe to turn or reposition a patient every 2 hours. So every 2 hours is the minimum that you can wait to reposition a person. So the soft tissue is able to handle up to 2 hours of pressure, in other words, without movement and impairing the perfusion to the skin or that area where the pressure is applied without causing irreversible damage. So in that sense, it's safe. So the difference now is when we assess skin and we look at areas of redness, you want to check for its capillary refill in that area. Is it blanchable, in other words? Because if it's blanchable, then I can say that there's still perfusion being delivered to that area of the skin. Even though it's red, it's hyperemic. If it blanches, then there is still a line of perfusion going there. If I press that area of redness or hyperemia and there's nothing that changes, there's no blanching going on, it's a non-blanchable reddened area, I can say that there is no perfusion stored to that area. And that tissue is now going to become hypoxic and die away. So pressure ulcers are defined by an area that is non-blanchable. And so we can say that area has been under too much pressure for greater than 2 hours if it's non-blanchable. Hyperemia, then, if I can blanch it, then I would say there's perfusion to that area and it's been less than an hour that that area has been under undue pressure. And that's why it's still viable tissue. So just to reiterate, pressure ulcers are defined as an area of redness or hyperemia that is non-blanchable. It has to occur over a bony prominence if I'm going to call it a pressure injury. If it's not over a bony prominence, you cannot define it as a pressure injury. Okay. Pressure injuries on the next slide, 18, are regulated by agencies. Medicare and Medicaid will refuse to reimburse a hospital for pressure ulcers that are acquired in the hospital. So this is why it's really, really important to understand the difference between what is a pressure injury and non-pressure injury. Um, so non-blanchable area of redness over a bony prominence is a pressure injury. So remember, we don't stage ulcers that are not over a pressure injury area. And that's something I'll define a little more in a few minutes with you. All right, so common areas that we can see pressure injuries occurring common sites would be our sacrum, trochanter, the hip area, and the heels. Those are the most common areas, but they're not the only areas that we see pressure injuries occurring. And I will outline those areas for you in a minute. On the next slide, 19, what you do to assess a pressure injury is important. You need to identify the location. Over bony prominence is significant. And then we want to measure the area. So you would measure the size, the depth, and measure the length, the width, and the depth of the wound. And if there's any other significant findings like undermining or tunneling, then you would make note of those also. And I will define that further on in a few minutes. You also want to make note of the color, the basement of the wound. What does the color look like? And then we're going to stage it. You want to pay attention to the wound margins. So what does the shape of the wound look like? Is it round? Is it smooth? Is it jagged? Is it oval? What shape is the whole wound? And then you also want to pay attention to the skin that surrounds the edges. So the healthy skin, what is the condition of the healthy skin just proximal to the wound itself? And lastly, you want to look for signs and symptoms of infection, which would be our HYPER acronym, looking for heat, induration, pain, edema, and redness. All right, and our next slide, slide 20, is going to outline where our pressure sites are the pressure injury areas for a pressure injury wound. The most common sites are on this picture. The head, it would be the back of the occipital bone, the ear. You could see it on the chin or the nose or the forehead, depending on where they've been. Like if they've went to surgery, for example, and they were positioned face down, then that would be significant for that patient. The next site would be on the back, the scapulas, the elbows, the sacrum, the trochanter, the hips, the knees, and the heels. Okay. On slide 21, what do we do and how do we manage pressure injuries? So first, you want to identify patients at risk. So we went over that using the Braden scale. It's really important to identify the patients. If we can't identify them, then we can't prevent these injuries from happening. So identifying the patient is first, and then implementing strategies to decrease risk factors for those patients. 2 would be to promote nutrition, and 3, maintain a healthy skin hygiene. 4, avoid skin trauma, and 5, provide a supportive surface for the patient. So first, when we look at prevention or our management, we're going to talk about nutrition now. You want to promote a positive nitrogen balance for this patient. A high protein diet would be significant. You want to assess their albumin level and maintain a normal albumin level, because this will indicate adequate protein stores and the ability to regenerate collagen synthesis, and the immune function to help wound healing is then considered adequate if they have normal albumin levels. So high protein diet, positive nitrogen balance is really important. Zinc is also critical in the normal wound healing process as far as other elements to consider. Proper hydration, monitoring their body weight, also other things to back of. The areas, if they look inflamed, you don't want to apply more pressure to, it only decreases pressure when you do that. So don't massage over the prominences for that. And you want to keep it clean and dry. Just use mild soaps and minimal friction over the skin when you're washing them down. Avoid hot water. You want to use temperature water. And you want to also make sure you're moisturizing the skin after bathing. Never use alcohol-based skin products. The alcohol just dry the skin out further. We also want to pay attention to those areas that are considered moist or at increased risk, like the perineum areas, or areas where the wound may be draining a lot. You want to consider using some type of skin barrier over the healthy skin to protect that from becoming injured. Okay, so next, avoiding skin trauma. So the best way to avoid trauma to the skin is to reposition your patient. So we want to turn the patient every 2 hours or more often. Avoid dragging them when we reposition them also. This minimizes friction and shearing injuries in that case. So using a draw sheet or some other device to help reposition the patient is important. Keeping the head of the bed no more than 30 degrees elevated for prolonged periods of time is important. Elevating the head higher than 30 degrees only promotes like sliding motions on the bed for some patients. And it also applies more pressure to the perineal area and the hip area and the thigh area of the body where they're laying or sitting. So it's not that you can't elevate their head ever, but you don't want to leave them in a high position like that for a long periods of time. And it is also really important to maintain whatever's underneath the patient to be wrinkle free. The wrinkles themselves can become sources of pressure. So you'd want to make sure that it's smooth and no wrinkles are formed underneath them. All right, next, making sure you've chosen the proper surface for the patient to be on. So providing supportive devices that help spread out the pressure areas that the patient's sitting under. So it reduces pressure, distributes pressure points, is why we use these supportive devices. Examples are overlay mattresses. You may have seen the air mattresses that are placed on patients' beds sometimes if they're identified as a moderate or high risk patient. They may have gel or foam overlays also. And then the patients who are really high risk are going to use replacement mattresses like the alternating air mattresses or high-low air loss mattresses, for example. We also want to protect the heels. So the heels are one of the more common places for pressure ulcers to form. So, and the heels are so simple to protect. Simply lifting them off the bed is all you need to do. And you don't need a special device to do this. You can use a rolled up towel, blanket, or a pillow. It's all we need to elevate the heels and protect them. And then make sure you're assessing the 4 Ps, pain, position, potty, and perfusion, as always, to reduce pressure. Our next slide, 26, is just examples of what happens when the heels are not protected. And some also devices that have been used to reduce pressure ulcer injuries or pressure injuries actually were the cause of the injury. So examples donut devices that people sit on. They still use them, but they're not on the market anymore. They're not recommended to help reduce pressure injury. They are actually have been shown to promote pressure injury in patients. So we would want to discourage the use of donuts and make sure you're checking the heels on every patient that you take care of, because the device itself can produce the injury. All right, so now we're going to talk about staging pressure injuries. Okay, so there are 4 stages that we use to stage pressure injuries. So, and we stage them on the depth of erosion that has occurred. So to enable to stage a wound or a pressure injury, you have to be able to see the base of the wound. So the other thing to keep in mind, make sure that it's a pressure injury. It has to be over a bony prominence for it to be considered a pressure injury. So we do not stage wounds that are not pressure injuries. So the first one we've already talked about, that was the erythema that was non-blanchable. That is a stage 1 pressure injury. Stage 2 is what we call partial thickness skin loss. So it involves the upper layer of skin. The epidermal layer is what is involved with a stage 2 pressure injury. Stage 3 is a full thickness skin loss. So stage 3 goes further down below the epidermis and into the dermal area of the wound. And you're able to see the fatty tissue in a stage 3. So it goes through all the first 2 layers completely into the subcutaneous tissue now. So that's a stage 3. Stage 4 is a pressure injury that has eroded all the way down into the muscle. And in some cases, you may even see the bone. So, but if it's into the muscle, it's considered a full thickness again, because all the layers of skin are eroded through the epidermis and dermis. And now we're looking at muscle tissue. So that's a stage 4. It's a very deep wound. Then the last thing I'm going to mention here is an unstageable wound. If you cannot see the base of the ulcer, you cannot stage the wound. Okay, so a lot of these wounds will have a lot of debris that has been secreted out of the lesion, and it's covering the wound. So sometimes it's referred to as sloughing, and that will look kind of sticky, pasty looking stuff, yellow, tan, green, gray, brown looking material is what it looks like. And then sometimes there's eschar. And eschar is that hardened scar-like covering. And they usually look black, tan, or brown. This is further discussed in your Koser book, Fundamentals book on page 831 and 832. So the next series of slides is just giving you examples of different stage wounds. So slide 29 is a stage 1 pressure ulcer, erythema that does not go all away and does not blanch. Then slide 30 is a stage 2 pressure ulcer. It's a partial thickness skin loss involving the epidermis. And it's a shallow crater. It involves also the dermal layer. I'm sorry, I didn't finish that statement. So it involves the epidermis and dermis. It's described as a shallow crater. Abrasions, that's an example, or blisters is another example. Then stage 3 is a full thickness wound involving damage or necrosis of the subcutaneous tissue. So stage 3 goes all the way into the subcutaneous tissue. It's a deeper crater, And a lot of times when we start seeing these deep wounds, they will develop other problems. One is called undermining. And undermining is what I equate to the box in of a roof on a house or building, how it kind of hangs over. Well, on your wound, you will be able to lift up the edge and go underneath it a little. So that's the undermining in the wound. It will also sometimes create tunneling. Once undermining forms, then you may see some tunnels, some little tracks that go real deep into the tissue, and that's called tunneling. The next slide, 32, is pictures of stage 4 wounds, pressure injury. Those are full thickness wounds that go all the way. We have destruction of the tissue all the way down to the muscle and bone, tendons you may see exposed. And definitely we'll see some undermining in a stage 4 wound. And also we may see tunneling occurring in these wounds. Bad thing about stage 4, the worst thing or outcome of a stage 4 pressure injury is that when the muscle is exposed, the bone is easily exposed as well, especially if you can see the bone and tendons. The outcome, the worst outcome of that can be an infection in the bone itself, which we refer to as osteomyelitis. Osteomyelitis is a very, very serious infection. It's very hard to treat the bone infections, and has a very poor outcome when we see that happen. All right, so the next part of this discussion is going to be, how does a nurse manage these wounds, these pressure injury wounds? So stage 1, the erythema that's non-blanching. The basic care that we will provide is to clean the area, use a barrier to protect it, sometimes apply dressing also to protect it. If the skin is very fragile looking, then we may put a dressing on it, but not all. Hydrocolloid used lactic kind of dressing. It's not use of that type of dressing, but you may see that applied to a stage 1 wound. You also want to ensure that the patient's on the appropriate surface. So do they need an overlay mattress on their bed? Do they need a more advanced mattress, like a replacement mattress on their bed? So addressing that is also important with stage 1 pressure ulcers. So we need to ensure that we're just redistributing the pressure that the patient's lying on or sitting on in that case, and avoid that area if we can. We don't want to turn the patient on that side if we can avoid it. All right, so stage 2 wounds, we again want to clean the wound, but now we have a break in the skin. So we have to really address protective measures to prevent infection and further breakdown. So we will use a dressing that can replace also the functions of the skin that are lost, since we have a skin breakdown. So we want to think about things that will help retain heat and moisture in that wound bed. So that's why we will pick a hydrocolloid dressing for a stage 2 wound, because it can protect the wound and provide that moist environment for it to regenerate new tissue. This is good to use on a wound that has no infection, a clean wound. If it is determined to have an infection, then we need to not apply a dressing right away, because we need to know what else needs to be applied to treat the infection. The hydrocolloid dressing may be used, but it won't be the primary dressing in this case. So protecting the wound itself. Then Then we also have to consider the good tissue around the wound. We want to protect that skin. So we want to avoid using tape on that skin if possible. And we want to use a skin barrier to protect it from breakdown as well. Frequent repositioning is essential with a stage 2. And then comfort measures, because this is a very painful wound. It goes into the dermal layer, and that's where our nerve endings and blood vessels are located. So it's an extremely painful wound. So comfort measures is important to address. And then we want to assess for signs of infection and signs of debris or necrotic tissue, sloughing tissue. We have to determine if any of that's going on. We need to treat that as well in this wound. And we'll get into those things a little later on. So essentially, clean the skin, protect the wound, and make sure it's not infected when we choose our dressing. If it isn't, we can use a hydrocolloid dressing type on the wound, and frequent repositioning and comfort measures are the treatment outline for stage 2. Stage 3 wounds, we're going to do all those things that we did for stage 2, but this is a worse wound. This is a wound that has gone down into the fatty tissue, the subcutaneous layer of our skin. So it's a deep wound. Deep wounds create what we call dead space, and we need to fill the dead space so that the wound will not progress and become bigger and worse. So we use alginates and hydrogels as a type of primary dressing for a stage 3 wound. Alginates absorb a lot of exudate and eliminate dead space. So alginates are good for a stage 3 wound because stage 3 wounds in general are very wet producing wounds. They produce a lot of discharge. And so an alginate will be able to handle that discharge. So comparing this to the hydrocolloid I spoke about and used on a stage 2 wound, hydrocolloids can absorb some discharge, but not a lot. So it would not be appropriate to use it on a stage 3 wound that's very wet in this case. So alginate would be the preferred primary dressing. A hydrogel is also a good dressing choice for stage 3 pressure injury because it can fill dead space. It also can wick away debris, discharge, drainage, but it's also really good to help break down the debris that's dirty inside the wound. So the sloughing discharge or necrotic eschar discharge, it will help soften it and liquefy it, and so we can remove it when we do our wound care and apply the hydrogels. It's also really important to assess for signs and symptoms of infection. These are deep wounds, so they tend to end up having some type of infection in them. So we would use some type of antimicrobial agent in conjunction with the alginates or hydrogels in some cases. Okay, so why do we need to debride a wound? That's on slide 36. So like I said earlier, if a wound has a lot of debris on its surface, it's not going to heal really well. This is a source that will delay healing of the wound. So we want to remove it. We want to debride it away and remove it and clean it out so that none of that debris is sitting on the wound bed. And we can promote what we call granulation tissue to form. Granulation tissue is simply new skin cells forming in the wound bed. And that's our goal when we do wound care, is to promote granulation tissue formation. So a stage 4 wound now is the worst type of pressure injury. It goes all the way down to the muscle and bone. So these patients, we have to assess what surface they're on, we have to put them on a specialized surface. So we're going to usually end up using one of the replacement mattress systems to place this patient on. We will more than likely need to debride a lot of necrotic tissue away, sloughing tissue away, and then determine if there's any complications like undermining or tunneling going on within that wound. And we definitely need to consider osteomyelitis as a factor in this patient's complications as well. So we will use dressings that will have to fill dead space, but also treat infectious processes going on in the case of stage 4. And debridement will have to also be part of the treatment, which we have to collaboratively do for stage 4 wound. Our next slide, slide 38, is just an outline of all the pressure injuries that we just defined so that you can see it in 2 different views. See how the depth looks for each wound. And then the last picture on this slide, I want you to pay attention to. It's an area on this patient's sacrum. It looks like a big bruise. It's over the sacrum area, the buttock sacrum area. And so it's a bony prominence area, bruised area that's non-blanchable. And so we want to define what that is. And this is the only injury I haven't defined yet. It's called a deep tissue injury. It's a deep tissue injury. And if you can, as you see in the picture, it shows the depth that it can possibly go down to. It can possibly be a stage 4 pressure injury. I can't tell because I cannot see the base of the wound. It's not open for me to see. But if it's non-blanchable and it looks like a bruise, not erythema, not hyperemia, in this case, a bruise, then this is considered a deep tissue injury, a suspected deep tissue injury until otherwise proven. Okay. So slide 39 is just an overview of different dressings and reasons we use a dressing. Okay. So the purpose of the dressing has to be considered. What do we need this dressing to do? Are we just protecting the wound like in a stage 1? Or do we have to consider an antimicrobial agent like in stage 2, 3, or 4? Do we need to debride the wound? Do we need to protect it? Do we need to provide a warm, moist environment for it to regenerate granulation tissue? So those are the purposes that you should start thinking about when you're picking out what dressing you want to use. So protect from mechanical injury, protect from microbial invasion, provides a moist healing environment, provides thermal insulation, absorbs the drainage away from the wound bed, debrides the wound, prevents bleeding, and it helps to splint the wound, immobilize it also. So those are general purposes for dressings. All right. And like I said, the next slide, 40, as the wound improves, the dressing choice will change. So it depends on what's happening in that wound at its stage of healing. Okay. On your Koser book, page 847, it discusses this a little further. So if you're not sure still about the choices of dressings and why we choose those dressings, refer to that page. So next series of slides is just to give you examples of what these dressings are. So for the slide 41, film is just an adhesive plastic. It's a semi-permeable dress. Don't just grab any kind of transparent film. It's meant for wounds. All right. It allows oxygen to go in and out of dressing. So an impermeable And it's impermeable to bacteria and water. So it protects the wound, but it allows oxygen to flow in and out of it, which is important. It also prevents shearing and friction injuries when we're moving the patient. So stage 1 is the primary reason you would use this type of dressing. Hydrocolloid dressing can be used on a stage 2, stage 3, and 4 wounds. Just depends again on what's our purpose for the dressing. So it's adhesive wafer, and you've seen them. Hydrocolloid dressings look spongy today. They look like foam dressings on the unit. You've probably seen them on patients. Or they may be this sticky, well, not spongy, but just plastic sticky, thick dressing called what I call a Duoderm. I don't know the brand names anymore of these dressings, but they adhere to the skin. You don't have to use tape. So as it heats up, it'll adhere to and mold to the area that it needs to cover, as opposed to the spongy, foamy looking dressing. Sometimes you have to use some kind of adhesive with them. So it allows inside layer, has particles that absorbs and exudate and moves it away, wicks it away from the wound bed. They absorb small amounts of drainage though. So if it's going to be a wet producing wound, this is not going to be your primary dressing for that wound. It does protect against microbial invasion and friction and shearing. Provides a moist environment, warm, moist environment for the wound bed. So it also can help promote debridement, or what we call autolytic debridement, and promote granulation in that sense. So when we use it as a debridement, we are placing it over the wound and we leave it there for days, up to 5 days. And as the body's own immune system reacts, it will slowly debride away the dead tissue in that wound. And in that sense, we call it autolytic debridement. And then the last one, page 43, slide 43, hydrogel is like a gel, like it sounds. It's a gel-based solution that we can put inside a wound to fill dead space, but also to help promote debridement of the necrotic tissue in the wound bed. It does require a second type of dressing to cover it though and hold it in place. So it helps to liquefy necrotic tissue and sloughing. It will rehydrate a dry wound and it will fill dead space. So in that sense, that's why it's good for stage 3 or stage 4 wounds. Also, alginate, the last slide that shows you an example. The alginates, the picture here on the left is a rope alginate, and then we have a wafer alginate on the right side. So they adhere to the wound bed. They fill dead space. They require secondary dressing also, but they're very absorptive. They absorb 20 times the weight in exudate. So provides a moist, warm surface and eliminates the dead space. And it supports debridement also of the wound bed and promotion of granulation tissue. So the last slide goes over reasons, just overall how we use these dressings. So avoid transparent film on fragile skin, because when we remove it, it will rip the skin up. Do use hydrocolloid dressings on fragile skin. And be sure that you are not applying it to a wound that's infected, though. We need to make sure that the wound is clean in order to use a hydrocolloid. Hydrogels liquefy tissue and sloughing. They promote autolytic debridement. And alginates will help absorb a lot of drainage and eliminate dead space as well. All right, so that is all about pressure injuries. Now we're going to move on to other types of tissue integrity problems. Lacerations, incisions, puncture, penetrating wounds, we're going to talk about. So lacerations can be what we consider accidental, unintentional, or intentional. A laceration that is accidental is like a accident, like it sounds. An open wound with usually jagged edges because it was a sporting injury, a motor vehicle injury, some kind of injury like that. And then we have our lacerations that are intentional, like medical procedures. So open wound, deep or shallow, with a knife or scalpel would be the result of that injury. Then we have abrasions. Abrasions are like scrapes that are unintentional also. And we have puncture wounds, penetrating wounds that are usually accidental, like a gunshot wound or a shattered glass maybe, or something like that. Or when it's intentional, it's usually due to some type of medical procedure, like a biopsy kind of procedure where they go in and they do a puncture culture, for example, of the skin in that case. On slide 47, it outlines that, how we classify these wounds. So I sort of did that a little bit for you. So there's intentional, results from therapy; unintentional, results from an accident. Open break in the skin is an open wound. Closed wounds can occur. Those are like crushing injuries, bruises, that kind of thing. Acute versus chronic. If a wound is older than 2 weeks, then it's considered chronic. So under 2 weeks, it's acute, but over 2 weeks, it's chronic. And then we can classify them by their depth also. But it's a little different from how we staged pressure ulcers, all right? So we have superficial wound depth, which is the epidermis. Partial thickness includes the epidermis and the dermis layer. And it will heal because it's into the dermis. It has to regenerate new tissue when we get into the dermal layer. So we'll have a scar form in some kind of fashion. Full thickness, epidermis, dermis, subcutaneous. We go all the way to possible muscle and bone with a full thickness wound. Okay. Penetrating wounds, for example, would be a full thickness wound. Okay. So how do we handle these types of wounds? Initially, with an untreated wound, it's usually an unintentional wound of some kind, right? They usually come in to seek medical help immediately after the injury. So you'll see these people in the emergency room. You want to first control their bleeding, prevent infection. So we will clean out the wound, flush it out. If it's an abrasion, a laceration, with saline, what we call normal saline, cover it with a clean dressing. Wrap it tightly enough to apply pressure to move the edges of that wound together if possible. And then we want to control swelling and pain. And then after that's done, we can assess the depth of that wound to see if it's a superficial wound, partial thickness wound, or full thickness wound. And then depending on that classification, we can determine the definitive way it's going to be treated. So applying ice also could be part of the immediate treatment plan for that type of wound. When we have wounds that were treated wounds, previously treated wounds, they come in. Usually we want to assess for complications of healing in these wounds. So you want to assess that really well. wound, the surrounding tissue, and determine the healing progress of healing, that the stages of healing. And all right, so in slide 49, just shows you examples of different wounds that we just kind of outlined. We move on to slide 50. This slide's really good. I thought it was pretty neat because it shows you the difference in defining the depth of the wound. So with superficial wound, it's involving the top layer, the epidermal layer only. Partial thickness, we're into the dermal layer of the skin. But when we go into a full thickness wound, we've just obliterated the whole 2 layers of skin. Now we're looking at fat, sometimes muscle, bone. So that's considered full thickness. So full thickness means the entire skin layer is gone. Now we're looking at fat. And then anything below that, okay, is a full thickness wound. And slide 51 is a comparison of these wounds that we're talking about now compared to pressure injury wounds, and how the staging of a pressure injury wound compares to the depth of another type of wound other than pressure ulcer. So you can look at that and make that comparison. So with any wound, we want to assess it by looking at the size, the depth, presence of undermining, tunneling. Sinus tracts is another name for tunneling. Means the same thing. What's important here is for you to understand, what do we do about the wound? How do we manage these wounds? So on slide 53 kind of outlines this by using this really neat acronym, RYB. R for red, that's what we do. We protect red. That indicates granulation tissue, new healthy tissue forming. Yellow, we need to clean it. That is when we see debris that's loose on the wound bed, like sloughing loose debris that we can clean away. B is black. Black is debris we have to manually remove, debride it somehow. So there's always going to be a mix of these different things in our wounds. It's never just one pretty type of wound. So we want to make sure we understand really what it means. So red, it's late regeneration phase of the tissue repair. So protect it. We need to protect it. We want to protect what we call the peri wound. I didn't use this word earlier. The peri wound is just a healthy wound, the healthy skin surrounding any wound. That's what they call the peri wound. So we need to protect that area of the wound with some type of skin barrier, okay? Fill the dead space if we have dead space. So we would use a hydrogel or alginate to fill the dead space, and then cover it with some type of secondary dressing. It could be a hydrocolloid dressing, or it could be some other type of dressing. It might be a ABD pad or some kind of other 4x4 pad to cover the dressing.